I would say yes, that there's an influx of patients.
Well, and it's all due to USAID
Right.
being canceled.
Right.
So USAID really support a lot of our patients with their medications for HIV/AIDS and also for TB. And when we talked to them recently over there, our staff is telling us that the bigger thing they're seeing is a huge growth in the TB diagnosis or disease in that area. So it's going out of control because they don't have the medicines they need.
Right.
Now, how that's affected us personally in our business, we used to have in the hospital, we probably have 5 to 6 patients on average at a time. Now we're up to 30. So that shows that change. So that's a change that happens because of what's going on.
And that's a monthly number.
That's monthly number.
So
Yeah.
it used to be 5 or 6 patients a month would go in the hospital.
So we're up to 30.
Right.
So we're seeing changes, and we know this is happening because USA has been canceled.
Right.
So that's really the thing that's really made this an urgent thing for us, or all hands on deck, because this is happening.
Mhm.
So what do we do to help these people? Because there are going to be more of them dying too.
They haven't seen it this bad in years. TB treatment is also a long process. It's typically
About a year.
6 to 9 months minimum.
Yeah.
And it's so contagious that we get people tested all along the way, so that when they think they're healthy and fine and want to quit dealing with TB, we want to make sure they get tested and are truly clear of it, because they've got family members, and if they're not done, then they're going to pass it to somebody else, and we're just going to keep going around and around. But the fact that it would cause us to have patients in our program for a much longer period of time increases our patient costs, our cost per patient per month.
Yeah.
Because right now, without a TB crisis, and without these new, the new influx of patients from other organizations, we are moving patients in and out in about 2 to 4 months, which is remarkable. But with this, it's going to, lengthen the amount of time we have to spend with them. It's going to force us to pay cash for drugs that aren't available through the patient support centers and hospitals.
And then it costs us more to care for them because of that.
And their kids, if they're like the rest of our patients, they have, 2.5 kids per family on average.
Yeah.
And so we do the math there, and we see how many orphans are being created potentially. The other piece were the CHVs and CHWs, those community health workers and volunteers. We use them to scale our team when we have situations like this. So thank God we wouldn't have to go through the hiring and interviewing and all of that process. There are people who are already out in the field doing, checking on people. And if we pay them, we can pay them to actually be another caregiver and supplement our team.
Yeah.
And it costs like $4 a day to have them do that.
So it's kind of that way we can scale up pretty easily.
But they're trained.
A lot of them are trained.
They know about the diseases, and they know about treatment, and they're in touch at a very local level. So those people really help us when we are in a flux and we've got we don't have enough people to deal with this. We can do that immediately, and it's pretty inexpensive. We have a fully trained person with a CHV. And we could double our staff.
Yeah, we could double our staff that way.
So we literally go from 9 out of 10 people dying without our help to 1 out of 10 people dying at the most.